lady who has come with, is it bad diplopia? Matt, you've got the sheet in front of you.
Yeah, so she's got severe diplopia with a enlarged right inferior rectus on her imaging, but clinically she doesn't really have much evidence in the way of thyroid eye disease. So it's just seeing if there's any likely differentials based on her imaging and whether we need to consider a biopsy for her, because it doesn't look like TID clinically.
Sorry, which side did you say, or is it bilateral?
Right.
Right, diplopia.
Yeah, so severe diplopia, but enlarged right inferior rectus is what was said on the scan.
So she doesn't have a typical history of thyroid, and it's just whether we should be biopsying that muscle, and if we biopsy, is it quite posterior?
Yeah. Okay. So we've got a T1 fat-sat axial, and you can see that there is a right-sided, is relative proptosis. So there is proptosis on the right side compared to the left. Mm-hmm. And the inferior rectus muscle is grossly enlarged with high T2 signal. And there is possibly some perimuscle abnormal signal, but you can see the susceptibility in artifact along the floors of both orbits. Let's just try and look at this muscle in a sagittal plane so we can see, or if we go forwards on this, you can see, or backwards, it's going towards the orbital apex. So it's almost, it is at the orbital apex as well. So it's right back and then going forwards. This is the central portion of the belly, then coming up, and then, well, we're losing it here. So let's look at the sag.
We're more interested in see how anteriorly it goes, because the access is going to be easier.
That's what I'm trying to help
anteriorly. Yeah.
So this is the normal inferior rectus.
Yeah.
And then if we go to the other side, so there's definitely the belly, and then as we come forwards, I think it's tapering out in the anterior tendon. Sweet. So if you took the anterior tendinous insertion, you might not get it, but it is. Okay. It's everywhere. If you look at the equator of the globe, or that line, whatever,
it's all post-equatorial then.
Yeah, then it's just behind that. That's where you need to start taking it.
Not easily accessible.
So if you look here, that's just this portion here is the normal insertion, normalish, and then it's not far behind it, but oh no, actually we're at the back of the globe here. So you will need to take it from the myotendinous portion, or the muscle itself. But then it goes all the way back towards the orbital apex. This is an atypical pattern. It doesn't fit for thyroid eye disease. And that we can look at DWI if we've got it. Yeah, it's a resolve, which is a not bad scan, but it's in the wrong plane. Yeah, I mean, we've got, if you believe the result, it is a markedly elevated ADC of around about 1900.
Wow, so we really should try to get it if possible.
Yeah.
Okay, fine. I think we need to look at this patient in the orbital MDT because it's not going to be accessible. We have to take the.
I think we've listed it for a biopsy already. I think.
Yeah.
It was just a case of where.
I think we probably have to take off the lateral wall, unless we can access it endonasally, of course. But then, yeah.
You could go through the ethmoid air cells and go to the. It's not that easy, but it's it's an awkward one.
It's closer at this point to the medial than the lateral wall.
Because via even a transcont approach, you'll be struggling to get beyond the equator, and you go on the, you can't, yeah.
It'd be interesting to see where the patient, if they've changed clinically, it'd be maybe worth getting an update.
Okay, well,
if they haven't, then you maybe proceed as is.
Yeah. But then, like, this is another girl who is hypothyroid, antibody negative, who's come with intractable double vision over the COVID period, has had IV steroids with some marginal improvement and then deteriorated again. And it seemed to be predominantly left inferior rectus involvement. But I think her other muscles are also involved, aren't they?
Yes, there's bilateral proptosis, but moderate on the left side. It's more, but it's 2 millimeters further on the other side, on the left side. And you can see that there is enlargement of the superior medial inferior rectus muscles. with asymmetric enlargement on the left side, particularly the inferior rectus, which is displaying high T2 signal. But there's also altered signal in the bilateral superior levator muscle groups, and it's going towards the orbital apex. So again, we've got confluent involvement right back to the orbital apex with some crowding, I think, on the left side. And
Matt, is she Hashimoto's or is she just pure hypothyroid?
Pure hypothyroid, as far as I can tell.
Yeah.
Just looking back a second. Yeah,
So I think
diagnosing hypothyroidism 2 years ago, so in 2019. Always on levothyroxine, different doses.
put that one up and then the original one, and then we can agree or disagree, if you like. So the original one on the right is from April 2020. And there we have the most recent, which is March 21. And my impression is that the muscle swelling has reduced in the craniocaudal dimension. The muscle belly is less swollen. It's slightly more patchy T2 signal inside the muscle, and it's less, it's more in the belly and less towards the orbital apex. So if you go towards the orbital apex here, it was definitely more swollen. So there's an improvement.
Oh, good. Okay, so that means that we don't have to biopsy her. And also there's other muscles involved, which will be more consistent with hypothyroid thyroid eye disease. So
I don't think so.
we're happy
hyperventilate
to
as well.
not biopsy and just monitor.
Just strike. Is it too strikingly asymmetric for the?
Yeah, I mean, I agree with Kunwa. I would keep a close eye on her because the pattern is quite odd still. There are lots of things that can cause myositis, obviously, but it's not typical for thyroid eye disease, in my experience, to cause really severe myositis in one muscle and then relatively spare the others. I mean, you do get real good changes in that.
You see this,
but it's someone else's. We do. Oh no, it's ours. It's Mary's. Oh, okay. Then,
I do believe
there
this,
is
this signal abnormality.
Yeah, and it's very levator, centered on the left, which is quite typical. Yeah, there you go. That comes forward that levator.
Yeah, I will buy this for bilateral.
So clinically, she's very unilateral, her symptoms, and that was why, because her clinical form is a bit atypical, in the minority. That's why we were curious.
She's going the right way.
And we've